Hi everyone, welcome to our Monty Heart lecture series. It's a great pleasure to have today Daniel Lorenzatti, who is from Argentina like me. He's originally from Cordoba in Argentina, where he did his cardiology training. And then he went to Spain, to Barcelona, where he did 2 years of advanced imaging in CT and MRI, and then worked as an extra year at a big hospital as an attending, creating the service for cardiac CT and MRI. He's now working with us here at Monty for a while. At least we're lucky enough to have him. He has a lot of experience, in particular in MRI and in arrhythmogenic cardiomyopathy. And he'll be talking today about this topic that I think is very important, very exciting, and with a lot of very challenging scenarios. So thank you, Daniel, very much for your time.
Thanks, Leandro. Are you hearing me okay here?
Yeah, perfect.
Okay, thank you for the introduction. It's truly an honor to be part of this series of Monty Talks. I'm really grateful and for the opportunity, and more so because considering the giants of the field that have spoken here in past edition. Today, I will be talking mostly in the imaging concepts and tools for the diagnosis of this rare but relevant disease that for sure we don't want to overlook in our clinical practice. This is only maybe the one conflict of interest I have. So to have some perspective of the evolution of our knowledge in this disease, we should start from the beginning. And this is probably the first large description of case series in ARVD in 1982. They described these typically enlarged right ventricles with overt wall motion abnormalities, but using only angiograms. And they correlated these segments with areas of fatty and fibrous replacement in the macroscopic appearance of the heart. The most affected areas of the RV were called the triangle of dysplasia. Look at the picture on the right. This is not a post-mortem image, as you could think. In fact, surgical treatment was the main therapy for refractory PT in the time. So although our knowledge of this disease has substantially expanded since then, the classical physiopathological definition of ARVC is still pretty much the same. In the word of a well-known expert like Professor Corrado, this is an hereditary heart muscle disorder that predominantly affects the right ventricle, in which the pathological heart is the progressive loss of the right ventricular myocardium at its replacement by fiber fatty tissue. It leads to predisposition to fatal ventricular arrhythmias, mainly in the young and athletes, and sudden death is sadly a common first symptom. So it goes without saying that an early diagnosis is crucial. So that's why for the first time in 1994, a specific task force integrated by the world experts established a series of structural, histological, electrocardiographic, and arrhythmic, and also genetic features for the diagnosis of ARVD. But the original imaging criteria in this consensus were limited by poor reproducibility and low specificity, especially in the family screening context. They lack of any quantitative and objective definition of anormality, and just only one of the following, the enlargement, the dysfunction, or the presence of regional right ventricular wall motion abnormalities were required for fulfilling the imaging categories. So this led to the famous revision of these criteria in a new international task force in 2010. This time, quantitative imaging reference values, including sex-specific index volumes, were added to grade the severity of the structural and functional right ventricular abnormalities. The association of RV enlargement or systolic dysfunction plus the regional wall motion abnormalities were not required in order to increase the specificity. With the publication of these criteria, cardiovascular magnetic resonance gained importance in the ARVD evaluation due to the known high accuracy and reproducibility in volumes and functional segments, so the referrals increased substantially. Yet, these criteria had, and they still have, because they are probably the most used still nowadays, some important caveats I would like to mention. First, the sensitivity is still suboptimal, and that's concerning because this is a disease we certainly don't want to miss. And second, the CMR reference values for the RV were derived from the MESA cohort volunteers with a mean age of 60 years and using the all fast gradient echo scene sequences that are known to underestimate the bolus due to a lower endocardial to blood pool contrast. Third, these criteria did not include the presence of LGE or fat infiltration by CMR assessment that were considered suboptimal for the RV wall with the image quality of the moment. And finally, and the most obvious one, is that these criteria are limited only to the right ventricle. Also, an important thing to underline is that the revised task force criteria allow the diagnosis of the RVD even without the presence of imaging abnormalities at all. In other words, we could potentially make the diagnosis using ECG and family history, for example. We must keep in mind that this is not the case for other cardiomyopathies like hypertrophic or dilated cardiomyopathies, for which the evidence of an imaging phenotype is mandatory for the diagnosis. So I bring you a case of a 27-year-old male with no relevant past medical history nor family history of heart disease, who was admitted for recovered sudden death. The ECG showed symmetric T-wave inversion from P1 to B2 to B3, and the transthoracic echo showed an enlargement of the RVOT and RV wall motion abnormalities at the free wall. At CMR, we can see that RV is mildly dilated with mildly reduced ejection fraction. But what first calls our attention, is that the RV free walls are very thin, almost indistinguishable of the surrounding epicardial fat. We also confirm the presence of regional wall motion abnormalities in the free wall and also in the inferior segments of the sagittal view of the RVOT. In the black block T1 weighted images, we see epicardial fat extending over the RV myocardium free wall, and in the LG sequences, we can appreciate areas of transmural uptake matching the segment with wall motion abnormality. So in this patient, we have two major criteria, the imaging one and the ECG making a definite diagnosis. Later, the patient was found to have a likely pathogenic variant in the plakophilin 2 gene, a well-reported gene for ARVD. This is a classic example of ARVD or ARVC with exclusive involvement of the right ventricle. But let me show you next what we have learned in the recent years about the full clinical picture of the disease. Thanks mainly to post-mortem investigation like this one and the genotype-phenotype correlation studies, we realize that this is a commonly a biventricular disease. This one is one of the largest postmortem studies to date from the group of St. George's Hospital in UK. They studied more than 200 hearts of patients with sudden cardiac death due to ARVD, and they found biventricular involvement up to 70% of the cases. Also, in about 17% of the cases, only the left ventricle was involved and showed the classic hallmark of the disease. But what is most striking of this study is that almost 80% of the patients were previously asymptomatic, and 20% of the heart looked normal at the first inspection. Actually, the LV dominant disease was already reported even before the gathering of the 2010 task force by the group of the Professor McKenna in UK. They realized that some patients with desmosomal mutations presented with unexplained arrhythmias of LV origin and inferolateral T-wave inversion. Also, they commonly had subepicardial and mid-myocardial LGE in CMR that correlated in the histopathology examination with fibrofatty replacement. In addition, when we look at DCM cohort like this one, we found a relevant proportion of desmosomal mutations that present with a dilated cardiomyopathy phenotype. They tend to have higher burden of sudden death and left ventricular arrhythmias, similar to laminopathies, in contrast to the other classical DCM variants like titin or sarcomerics or the genetic negative patients. Also, I want to highlight on the right that the EF did not appear to have an impact in arrhythmic events in this subgroup of desmosomal variants. But of course, we must keep in mind that we was a small subset of patients. This is a fascinating manuscript from the Bart's group in UK, where they looked at genetics and imaging features in patients with DCM-related mutations. They used clustering analysis and identified two different groups, one with desmoplakin and filamin C mutation, and the other group involving titin, lamin, sarcomeric, and the sodium channel variants. The desmoplakin and filament C variant had more commonly this extensive ring-like subepicardial or mid-myocardial LGE, but less impaired ejection fraction, in contrast to the other group that had less scar, but more reduced LV ejection fraction and global longitudinal strain. And importantly, in up to 50% of the left arrhythmogenic variants, did not have wall motion abnormalities, suggesting a key role for the tissue characterization in this patient. This is another genotype-phenotype study, this time from the University of Granada in Spain. These patients had definite or borderline diagnosis of ARVC, and they separate three groups according to the presence of desmosomal or non-desmosomal mutations and genotype-negative patients. They reported more right ventricular involvement with desmosomal mutation, but this time, the most commonly associated ring-like appearance was the desmin, which is a non-desmosomal gene which codifies for an intermediate filament with a key role in the cardiac muscle. They also noted, as shown in the previous paper, that the presence of LGE was not associated with concomitant wall motion abnormalities, and this could be explained by the common sparing of the endocardial fibers. This is another elegant study from the Professors Corrado group in Padua that looked at a big cohort of patients with ARVD and compared it with DCM patients using clinical examination and CMR, including LG quantification. They confirmed the common presence of LV dominant and LV isolated phenotype among ARVD cohort, and then reported also typical LG features of LV arrhythmogenic cardiomyopathy, like low voltage complexes in the leaves and the inferolateral T-wave inversion, in contrast to the most classical DCM ECG findings like left bundle branch broad. Using these imaging features, they described two patterns of remodeling: a DCM remodeling type with a myocyte contractility impairment that leads to a more dilation and eccentric hypertrophy with less amount of scar, in contrast to the arrhythmogenic left ventricular type that have more frequent and hypokinetic, not dilatic phenotype despite extensive fibrosis in CMR. The fact that less than 50% of the DCM patients had presence of LGE could be important for the differential diagnosis. So I bring you this 18-year-old boy with no family history of cardiomyopathy that consulted for syncope while playing soccer. This was the second episode in 2 years. He was already evaluated 2 years ago, and all the tests were normal. We can see that now he has an abnormal ECG with T-wave inversion in the lateral leads. CMR showed a significant LV enlargement, but a mildly reduced ejection fraction. Right ventricle is preserved. With this appearance, we could probably think of a DCM, but if we look at the LG sequences that showed extensive subepicardial and mid-myocardial circumferential uptake, we can think of an arrhythmogenic phenotype. When we encounter this subepicardial LGE, especially in the lateral wall of the LV, like in this case, it's useful to compare with the cine images and also to acquire maybe fat-sat LGE sequence to be sure that we're not misinterpreting true LGE for physiologic epicardial fat. In this patient, the genetic test was positive for desmin mutation, and taking all in consideration, a subcutaneous ICD was recommended and implanted. At the follow-up, the patient presented an appropriate shock for BT. So we're currently leaving behind the traditional model of ARVC and the triangle of dysplasia to embrace a more contemporary one that considers the common LV involvement of the disease and the DCM-like arrhythmogenic phenotype, along with the use of multimodality imaging for the diagnosis. So to account for this change in the paradigm, in 2020, the international experts joined again in Padua for developing new criteria. Now, there are separate criteria for the right and for the left ventricle, and we have two different categories in imaging: morphofunctional and structural abnormalities, including CMR tissue characterization. The volumes and the EF cutoffs were removed from the criteria. They just recommend to use literature imaging sex and age specific nomogram for establishing dilation of dysfunction. The typical LGE pattern is mentioned in the right as transmural and in the left as being subepicardial or mid-myocardial involving the septum or the lateral wall or both. An important difference of this Padua consensus, in contrast to the 2010 task force, is that the fulfilling of at least one imaging criteria is mandatory for the diagnosis, regardless of the other clinical findings. In other words, no, we need the presence of an imaging phenotype, like was hypertrophic or dilated cardiomyopathy for the diagnosis. They also have included the ECG criteria that are the T-wave inversion in the lateral leads and the presence of low voltage QRS in the limb leads. So based on this imaging phenotype, we have three presentations of the disease: the dominant right, the biventricular, and the dominant left arrhythmogenic cardiomyopathy. Importantly, for the dominant left, the presence of a concomitant related mutation is required together with the imaging findings for the diagnosis. You can see in the upper right the most common reported mutation with the predominantly involved chamber. Despite these new criteria, sometimes the differences with mimic entities could still be challenging. We have seen the distinct and overlapping features of DCM with DCM. To summarize, we could say that overall DCM presents more often with a dilated and globally hyperkinetic LV with no presence of LGE in more than 50% of the cases, and when it's present, there is a mid-wall but patchy LGE pattern usually involving the septum. We can see on the right the classical example of a DCM with significant adverse remodeling despite the absence of LGE and the presence of the so-called apical rocking, which, as you know, is a marker of desynchrony and also a reported predictor of favorable response to cardiac resynchronization therapy. One of the distinct features of ACM is fat infiltration, and although this is not included in consensus criteria, it is something to look to support the diagnosis. We can see fat very well with the MR, but also CT does a pretty good job in both contrast and non-contrast acquisition. Look at this case of advanced stage biventricular ACM. This classic fat infiltration gives the myocardium an appearance that is called as the rat bite sign, in reference to a cheese beaten by rats. We also must keep in mind that there are other settings in which we can encounter myocardial fat, like chronic post-MI metaplasia. I recommend this excellent review on the topic. Another mandatory differential is viral myocarditis that, as everybody knows, present in two different scenarios. In a chronic setting, we should rely in clinical and family history for the differential. It is unlikely, for example, to encounter significant amounts of scar without the clinical history of a past episode of myocarditis. Of course, genetics could help, and also the presence of fat infiltration, as we just seen. In the acute setting, we can use the well-known Legg-Lowes criteria for the differential diagnosis, but as we are going to see in the next slide, this could still be hard, especially in the COVID time. Here we have two examples. On the left, there is a 21-year-old girl presenting with acute chest pain, a troponin elevation in the context of a COVID infection. He had mildly reduced ejection fraction, but as you can see, extensive LGE in CMR. Due to the concern in family history, a genetic test was ordered that came up positive for a likely pathogenic mutation variant in a desmoplakin gene. She later had a non-sustained BT and follow-up. On the right, we can see a 34-year-old male that presented with syncope and BT. He had severe LV enlargement and dysfunction with ring-like mid-wall and subepicardial LGE on CMR. He underwent endomyocardial biopsy that found the coexistence of lymphocytic myocarditic changes with adipose tissue infiltration. Genetic testing also came out positive for a desmoplakin pathogenic variant. So this inflammatory presentation of ACM has been described recently in this manuscript, also from the group of Padua. Authors concluded that this hot phase is an uncommon clinical presentation of ACM, which often occurred in pediatric patients and carriers of desmoplakin mutation. In this setting, tissue characterization using CMR along with family history and genetic tests are fundamental for the diagnosis. I would like to add here the critical importance of a follow-up CMR scan, because commonly acute myocarditis, LGE, tends to become less prominent in the follow-up, in opposite to cardiomyopathies in which fibrosis often progresses or stays the same. An important difference is, of course, sarcoid. This disease shares, perhaps with ICM, a common clinical picture regarding myocardial scarring with dilation of the function leading to ventricular arrhythmias and heart failure. For the differential, we should look for the clinical features of sarcoid, such as conduction abnormalities and, of course, pulmonary infiltrates. Despite the classical statement that sarcoid could present with any ischemic and non-ischemic LG pattern, there is recent and good quality data published about the most common LGE features of the disease. It has been shown that the LV multifocal subepicardial involvement with RV septal and free wall compromise are very suggestive patterns. I bring you this case of this 50-year-old female with no relevant past medical history that presented with sustained VT. Echo shows basal septal thinning and biventricular dysfunction. Invasive angiography ruled out coronary artery disease. In CMR, we can see a visually thick LV with a very bright and thick LGE uptake with a non-ischemic distribution involving extensively the RV septum and the hinge point with extension to the inferior wall of both ventricles. Note the almost transmural scat in the basal segment. We can see that this case looks quite different to the cases we have seen previously. So this patient underwent PET and CT, PET-CT and endocardial biopsy that confirmed the diagnosis of cardiac sarcoid. These are other LGE findings reported by the group of Ron Blankstein and Professor DiCarli in Boston that increase the likelihood of the diagnosis, and those are the high-intense LGE signal for the LGE uptake and the so-called hook sign. Unfortunately, we are still struggling with the differential sometimes. Look at this case report, for example. The patient had a strong family history and presented with exercise-induced trigger VT. CMR and PET were suggestive of sarcoid. The patient responded to anti-inflammatory treatment but had recurrent VT in the follow-up. A genetic test came out positive for a pathogenic variant like plakophilin 2. But if we look closely to the CNE4 chamber stack in the supplemental material, we can see the rat-bite appearance of the LV free wall together with typical RV dilatation and regional wall motion abnormality suggestive of a biventricular HCM. So what about risk stratification in HCM? The question is imaging can help? Can imaging help? The actual recommendations are mostly based in expert opinions. In reference to imaging, they only mention RV or LV ejection fraction for risk stratification. Recently, a new score was developed in a similar way to the European HCM risk tool. It uses clinical and ECG parameters along with the RV ejection fraction for predicting the 5-year risk of late-treating ventricular arrhythmias. Seems to perform better than the guidelines recommendation with up to 20% less ICD indication without a penalty of increasing risk. Yet, it still has some limitations since only considers the RV ejection fraction among the imaging parameters and was developed from a cohort with predominant plakophilin mutation, mostly related to the RV dominant disease. It is important to underline that unlike the HCM risk score, this one does not provide a risk threshold to suggest or recommend the ICD implantation. This website is available for the IRBC risk score. So the IRBC 5-year risk score has been validated in an independent large cohort, confirming the better performance in predicting events compared to the previous expert recommendation, although it remains imperfect with a C statistic of 0.7. The authors in this paper also refused to give a cutoff risk for the ICD implantation, but they imply that somewhere between 5 and 25% of risk is a reasonable number. They emphasize that this calculator should be used as a shared decision-making tool. So the question sorry. So the question is still if we can do better with imaging. This is the largest prospective cohort of ARVD evaluated with CMR and follow-up about for 5 years. They've shown that the 5-year ACM risk score significantly underestimate the risk in patients with LV dominant and biventricular phenotypes, and CMR was able to reclassify those patients with LV dominant disease. More importantly, there were no events in patients with a normal CMR scan, supporting the concept from Padua that the imaging phenotype must be present for the definite diagnosis. So they proposed this algorithm for recommending ICD implantation using together the 5-year risk score and the CMR phenotype. As a final case, I would like to show you this 57-year-old male with family history of sudden death but an old age. He had a history of AFib and high burden of ventricular ectopic that were treated with radiofrequency ablation. He presented again with frequent ectopic beats and he had good tolerance to antiarrhythmic drugs. Transthoracic echo was normal. He was sent then for an EP study and re-ablation. At the EP lab, with the infusion of low-dose isoprotenolol, the patient developed polymorphic ventricular ectopy and non-sustained VT, so the procedure was aborted for further evaluation. Patient underwent CTA that ruled out obstructive coronary disease, but in a closer look to the study, we could see septal and lateral areas of low attenuation within the myocardium, concerning for fat infiltration. You can see there that the Hanfield units were in the fat range. This was confirmed with CMR. And in CMR, we can see the confirmation of the intramyocardial fat in the cine, T1 weighting, and T1 weighting with SAT-fat images. There are several multifocal spots with fat infiltration, and there is also subepicardial LDE involving the basal to mid-inferior and inferolateral segment and focal transmural scar in the area of the papillary muscle related to the previous LV ablation. Unfortunately, in this patient, we are still waiting for the genetic panel. So this is the recommended CMR protocol for HCM evaluation for the Padua lab. It's fundamental to use dedicated RV views with thin slices, and in difficult cases, use a transaxial cine stack for better depiction of right ventricular wave motion abnormalities. Also, it should include T1 weighted or proton density weighted acquisition to assess for fat, and of course, LGE with the same dedicated RV planes as in the cine to look for IB fibrosis too. And if you want to push further the limit of spatial resolution, you can adjust the imaging settings to acquire high-quality cine sequences after the contrast for improving the signal-to-noise ratio. So as a take-home message, I would like to say that the phenotype and clinical presentations of arrhythmogenic cardiomyopathy are more diverse than we previously believed. CMR has a key role in the diagnosis, especially in the detection of the LV dominant types with myocardial tissue characterization. Differential diagnosis with mimicking entities could still be difficult, so integration of a clinical history, genetics, and multimodality imaging is fundamental. And last, the ICD recommendation should rely more on imaging phenotype, genetics, and scar burden than in EF. And I don't know if we have time, Leandro, for a last Jeopardy or?
Yes, we do.
Okay. We have a final case. If you want to comment on the chat, well, what do you think the diagnosis is? This is a 20-year-old male with no past medical history, normal coronary arteries that presents with PT. Any idea what this patient had?
Anyone? I know the answer, so what's the origin of the patient?
He's actually original from Bolivia, but living in Spain at the time. I cannot see the chat. Maybe you can.
I think we have no comments.
Okay. Well, don't worry. This was a Chagas cardiomyopathy. So thanks for your attention.
Very good. Thank you, Daniel. That was outstanding. Such a good presentation. I think, you know, the interaction between CMR and genetic testing is fueling each other of these fields into understand these pathologies better. So please put your questions in the chat if you have any questions, and we'll go through them. I think I'll start with one myself. I really like the comment you made about the myocarditis and the differential with myocarditis and the possibility of repeating these studies. And I know this can be done sometimes for early diagnosis too. So the question, I guess, is when would you repeat a study and what interval of time you would choose?
That's a tough question, because there's like concerning literature like about, but I think probably maybe in an interval of 3 to 6 months would be reasonable to repeat the CMR scan after an acute episode of myocarditis. The thing is, as you pointed out well, is that in the acute setting you have inflammation, so the LG appears more than it usually is. It's not that the fibrosis recovers, but because we know what is dead is dead. But the tricky thing is to use the follow-up scan to reassess the LG quantity there, because it usually in the acute setting it looks more than it really is because of the edema and inflammation.
I think Mario was trying to join us here. Let me just let him into that. Mario, you want to join?
Yeah, sorry. It looks like the chat is disabled. I just wanted to let you know.
Oh, it's in the. We have Dr. Garcia for a.
Yeah, sorry. It looked like the chat is disabled. I was trying to make a comment and I couldn't use the mic or the chat. So, you know, I have to double on what Leandro said. The presentation was excellent. Very well done. Very well done. I just want to make a comment that this is one particular condition that I think the guidelines are, you know, only partially helpful. That, you know, the diagnostic criteria based on the guidelines we still miss quite a big number of patients. As you demonstrated with the last case, you know, there are clearly many patients who have arrhythmias who do not have any morphological criteria by echo as per guidelines.
Yeah, I agree totally with that.
Okay. I think we have some questions from Jay Chudo. He says, what role is there for CMR imaging in relatives of those diagnosed with these diseases?
Oh, also a very good question. And in that regard, you should always take in consideration the cost of the study and the thing you have to gain. I would probably go for the genetic testing if you have identified the proband with a mutation, and do the ECG, maybe a treadmill test and an echo before going to CMR in a relative, if the patient is asymptomatic and it is not showing any kinds of symptoms for the disease. I think the CMR should be reserved for maybe for the gen when you have a relative with concerning alterations on the normal studies and or a positive genotype, you know.
Yeah, that's very good. I think, right, if you have identified the gene already, you can test for that gene if you have the availability. But then I think it's very important, like we were discussing for the case the other day, that the penetrance for some of these diseases is not always the same. So
yeah,
right,
CMR
probably can help with that.
And yeah.
So great question. One question from Yogita Roshani, that she's been actually using CMR and identifying some of these cases. She says, I had a question about how to approach differentiating between sarcoid and arrhythmogenic cardiomyopathy, particularly isolated cardiac sarcoid. Do you always do a genetic test or only consider it a sarcoid if you have either cardiac or extracardiac tissue diagnosis?
No, I think this is a very good question also, and I think I showed in a couple of slides that while sarcoid has like this typical feature, sometimes when you have an early disease or a different or of an isolated cardiac sarcoid could still be challenging. I think in that regard, I think PET imaging could help, and the other thing, of course, genetic testing if you're having doubts within those two diagnoses. But I think most of the cases with LGE, you could probably have a suspicion of sarcoid against ACM.
Yeah, so we'll have a full dedicated talk, Yogita, on sarcoid and the different patterns to suggest it as well. But it's sometimes when it's isolated, it can be tough as well. I agree. She also asked, do you use a scar burden cutoff for ICD implant?
No, I haven't seen literature published in that regard. The only study that I show from the Padua, they use this threshold of 20% LGE, but for differentiating DCM, non-classical DCM from the LV arrhythmogenic cardiomyopathy, but not for indicating an ICD. Probably if you have that amount of scar, these patients with the ring-like scar, and you have a positive genotype, it's very hard not to recommend an ICD. I think more so if the patient had no sustained VT or syncope or high burden of arrhythmia in the Holter.
Yeah, that's true. That's very tough. And I think one last question. Do you see, is there any role of parametric mapping in these cases?
Yeah, it's a really good question. There are very few studies. The thing that this is a regional, like a regional disease, mostly like sarcoid, like multifocal, is maybe tricky for using mapping as a tool for identifying, for example, diffuse fibrosis. But I imagine that with T1 mapping that is too good, is very good for identifying fat, as we can see in Fabry disease patients. We can use that in HCMs to look for fat infiltration, but there are not literature available that have demonstrated clearly that you can use mapping for improving the diagnosis in this disease.
Okay, great. Thank you so much. This was outstanding, and well, I'll see you around.
Thank you very much to you, and thank you all for your attention.
Okay, great. Bye-bye.
Bye.